A very good day, my dear postgraduate students. I welcome you to a topic from Recent Advances 22, Osteoarthritis, its newer concepts. The authors are Anthony Fremont and Judith Hoyland. Also, I have mentioned in the inset the context to which this can be applied or related to, so that you find that there is a continuity in your reading. Just for a case discussion, I would like you people to kindly go through the case and find out the key words from it. Incidentally, this happens to be an X-ray, and what you are finding is you can superimpose it on the pictures to come. It can also be called as osteoarthrosis. So if this comes in your question paper, do not be bewildered. And Robbins himself defines it as a degenerative joint disease characterized by the degeneration of cartilage that results in structural and functional failure of the synovial joints. The word synovial is important. There can be an inflammatory or an intrinsic defect in the cartilage. And this picture, it shows the Heberden's nodes. DIP means distal interphalangeal joints, and Burkhart's nodes, proximal interphalangeal nodes. We will have to compare this with the clinical pictures of rheumatoid arthritis, which I shall be showing you deliberately. This incidentally happens to be a mnemonic thanks to this rxpg.com. And beautifully they have just coined it, though there is not much of logic in it. Heberden's node, Burkhart's. And they say that B comes before H. That means the proximal interphalangeal joint is supposed to be B and distal interphalangeal joint is H. So intelligently and intellectually, these children have coined a mnemonic. Kindly follow it. This is just to enlist the causes of arthritis. Strangely, the list was without osteoarthritis, which I have included. Also, you find that when we mention the word osteoarthritis, or for that matter, the metabolic diseases of the bone, we are opening a Pandora's box. This is an area, or rather a no man's land, with which neither the teachers nor the students are very familiar with. So it would pay dividend if you can just concentrate on all my 40 slides, which are worth their weight in gold. The radiographic signs are loss of joint space, presence of osteophytes, subchondral sclerosis, and subchondral cysts. A lot of such things will be coming, but the key words we should always be bearing in mind. So this is again an explanation of the same. I would like you people to kindly go through it. And this incidentally is an X-ray that shows the distal joints being more involved than the proximal. And the rest is relatively free of lesion. This again is a very weird slide that I happen to pick up because almost all are mentioned as phenotypes. That is why I had put it in this as whether the disease of osteoarthritis itself is acquired or genetic. Look at this one. There are the primary phenotypes and then the secondary phenotypes. There can be intra-articular phenotypes, extra-articular phenotypes. And all these are being given over here, starting from aging up to the formation of crystals, the inflammation, etc., are all being enclubed under the word phenotype. So just have this in mind. It will help us when we study the answer. This is quite a complex topic as such. Before I plunge directly into the topic, a word about the difference between rheumatoid arthritis and osteoarthritis. Both of them occur beyond 40 years of age. Rheumatoid in a relatively older age. So in this one, the joints that are involved are the metacarpophalangeal and the proximal interphalangeal. Whereas in osteoarthritis, it is the distal interphalangeal joint and the carpometacarpal joints. Haberden nodes, as I showed you, is absent in rheumatoid, present in osteoarthritis. There will be the signs of inflammation in rheumatoid arthritis, whereas it is hard and bony in osteoarthritis. Stiffness varies. And here also there is an evening stiffness, whereas here it is morning stiffness. And the laboratory findings, amidst other things, rheumatoid factor will be positive, whereas it will be negative. So what is your diagnosis in this case? Is it rheumatoid arthritis or is it osteoarthritis? Going back to a mnemonic. So in osteoarthritis, I find that there is a loss of the joint space, osteophytes, subchondral sclerosis, and subchondral cysts. So look at this region. There are cystic lesions which I could make out. Whereas rheumatoid arthritis, the wrist is almost destroyed. There can be erosions. There will be swelling of the soft tissue. And the bones develop a severe osteopenia that you can see through them. Classification is an aid to orderly thinking. Now, this is not a WHO classification, but the classification of the subsets that have been given in this particular topic. The authors have dealt with this recent advance under all the subheadings that have been given. So many of them that I took the pain of dividing them into relatively important and not so important. But the star marks indicate that they will have to be mentioned. So this will be the sequence with which we shall try to understand the topic. So please do remember, think of the subheadings. The subheadings will take you to the answer. Always, we should know the normal before trying to understand the abnormal. What is the normal structure of a synovial joint? It is quite thin and bound to bone. So it has got a bone end plate or BEP. The blood vessels penetrate the bone to produce nutrition to the cartilage. The cartilage itself is mainly supported by the extracellular matrix, which has got two components, namely collagen type 2 and proteoglycan. These words we can never afford to forget, because when you go into the molecular and the genetic basis of this, these words will continue to haunt us. The articular cartilage is a hyaline cartilage. It is about 2 to 4 millimeters thick or thin. And it does not have blood vessels, nerves, or lymphatics. All these are being derived from the subchondral region. It has got a dense extracellular matrix. And there will be a sparse distribution of the chondrocytes. This will be appearing a little difficult to comprehend, but we shall superimpose it on the pictures. Here is a gross diagrammatic picture of a synovial joint. So there are a couple of bones that are covered by the synovial membrane, and I find that there will be a bursa by the side and there will be a joint capsule. This is not the synovium. This alone is the synovium. Please do remember. The muscle, the tendon, its insertion, etc. are all very beautifully depicted in this diagram. Always when there is a picture, spend at least a few seconds trying to understand, because in the end, it will be the picture that comes to your mind, not the words. Again, a very beautiful schematic picture of the same. What is the joint after all? I find that this is the joint surface or the articular surface. And there are different zones that have been mentioned. Almost 4 zones have been mentioned. And these are all made up of bundles of collagen. And the main thing is proteoglycan and aggrecan. Aggrecan is the main component of the proteoglycan. So you find that there is a kind of looping over here, and this collagen, very intricately, it gets connected to the superficial cartilage. As a result of which, you find that the integrity is maintained, tethering. So know the normal. There is a bone over here, there is a calcified cartilage, and then there will be the bundles of collagen, there will be a loose matrix, and this is the joint surface. And look at the arrangement and the direction of the collagen fibers, so much so they provide the strength to the joint. This again is very beautifully depicted. Repetition is the mother of knowledge. I have intentionally included even this diagram. So there is a tangential zone, there is a transitional zone, and here they are all radially arranged. And this is the tide mark. Tide mark is just one line that I am seeing that demarcates between this and the underlying ossified cartilage and subchondral bone. These are the histological zones in a hyaline cartilage. So that is how the integrity of the joint is being maintained. Synovium and synovial fluid. As a postgraduate student, this was actually one of the difficult slides for us to diagnose, because we are not very familiar with a synovial tissue as we were with the endometrium or a gastric biopsy. The bone is covered by the synoviocytes. And do you people ever know that it is made up of a couple of cells, namely the macrophages and the fibroblasts, which secrete the hyaluronans? So A and B, these are the 2 layers that alone are there, and which is the synovial lining, beneath which there is a subintimal fat and a fibrous tissue. And still below that will be the blood vessels and the nerves. So it will be these that will be branching and percolating to provide the nutrition to the cartilage and the synovial tissue. And within the joint space itself will be the synovial fluid, which is nothing but a transudate of the plasma. This is very important. I would like you people to kindly superimpose this knowledge on my classes of gout, rheumatoid arthritis, so on and so forth, and interpretation of the synovial biopsy. So what is happening? So this is the normal bone. I need not divulge much about it. So there is a cartilage over here, there is a bone, and these will be the synovium over here, and this is the joint space, as I had mentioned. There is a meniscus or a horizontal ligament, and also you find that there will be the crossing ligaments which are there, and these will be damaged in a case of osteoarthritis. So there will be a kind of bone remodeling, there can be a sclerosis, the cartilage can break down, and there can also be a meniscal tear. The synovium, instead of having 2 layers, it undergoes a hyperplasia. The osteophytes, you find that after all this damage, there will be the spurs of the bony tissue that go into the joint space. So you can very well imagine the havoc it can play if it is a weight-bearing joint. So please compare the normal with the osteoarthritic knee. This is a very superb picture that you people will have to remember. So this is a normal joint, the contents of it. Kindly spend some time, go through it, see whether you can understand all the parts. Coming to the cartilage itself, I find that there are three zones. There is a superficial zone, there is a middle zone, and a deep zone. And as you go lower down, you find that there is an interterritorial region which is increasing. The matrix is increasing. And lower down, there is a subchondral bone that is there. This particular line, as I had mentioned in one of the previous pictures, is called the tide mark, which demarcates. Tide mark, remember. Why it is important, we shall be seeing. And this again is a better histological picture showing the normal joint. So there is a cartilage, the various zones of it, and look at this tide mark again. It is aligned. And lower down there is the. Now, what will happen when there is going to be a damage? Leave alone, whatever be the cause of it, be it obesity or genetic, there is a change in the articular cartilage. And the surface fibrillation and fissuring is occurring over here. The tide mark, it undergoes a duplication, just like what you have a duplication in a case of the elastic membrane in a case of atherosclerosis. So I find that it becomes thickened. There is a duplication. There is a subchondral cortical bone that is also getting damaged at one end and also proliferating. Also, there is a vascular invasion leading to complications such as hematoma, hemarthrosis, and so on. So compare this with this, or rather this with this. So you will understand which is normal. Thanks to Nature Reviews and all the authors for this wonderful picture. I think if you do understand this, it will solve half our problems. The pathology of the osteoarthritis. I told you that proteoglycan is important. Collagen type 2 is important. Proteoglycan is very important. And aggrecan is one of the ingredients of proteoglycan which you people will have to mention. And what is this one? So this is the proteoglycan and HA. Later on, I labeled them as hyaluronic acid. And CS, the chondroitin sulfate. Aggrecan is one. So this particular unit is called the aggrecan. And what is it? I find that there is a central branch of this hyaluronic acid, and which is nothing but a glycosaminoglycan. And there will be the various chains of this chondroitin sulfate. This will be the structure of it. This can get damaged in a case of osteoarthritis. Not can, will be damaged. Thanks to this wonderful reference and the diagram. The articular cartilage, what happens? There is a pathogenesis. There is a loss of the proteoglycans. The aggregants are being lost in the superficial layers. There is a disturbance in the balance and due to pressure between the proteoglycans and the type 2 collagen. The collagen fibers become soft and they get split. Articular cartilage is also being destroyed, as in this diagram. The bone gets exposed. There is something called as hibernation, which I will tell you what it is. And the damaged cartilage has calcium pyrophosphate crystals. Hibernation is nothing but exposure of an underlying tissue during a pathogenic process. So this is the hibernation that you are seeing. The underlying bone is getting exposed. Hence the term osteoarthritis. If you are not convinced, look at these two. Look at the devastation caused by osteoarthritis. I hope your eyes will see through the differences. Subchondral bone. This is the first detectable change. there is an increase in the thickening of the subchondral bone and its density. There is an alteration of flow into the joints. Avascular necrosis, but usually the joints are spared. There can be elements of necrosis below that. The disturbed proteoglycan metabolism can be the cause for this. And macaque, bone is more than the cartilage. There will be a high resolution radiography which is required to make the diagnosis in the early stages. So it is basically an anabolic effect. Anabolic means there is a progressive build. Excess osteoblast deposition. Usually there is a balance between the osteoblast and the osteoclast. But here the osteoblast is moved, therefore there is deposition of subchondral sclerosis or fibrosis, osteophyte formation. This I will be showing you later. So these boxes and the tables, see how much we can remember. Subchondral bone. Again, it is repeated. So this is the subchondral bone, it is going up, the surface is getting lost, the articular cartilage, see what all happens. Also, in some areas, there can be a localized proliferation of the chondrocytes, whereas in other areas, it is getting lost. Now, what are the various studies that have been conducted in the animal models? The species of dog that have been taken is the canine fawn nuki. In this, the cruciate ligament has been studied. These are not very important, but then we will have to make a mention of it and bear it in mind because they are involved in the initial and the later stages of molecular pathology, one. And secondly, they can be used for targeted deletions or treatment. So probably there is a genetic background which is to be aimed at. And this incidentally is a diagram of the cruciate ligament in the canine. And look at this one. The cruciate ligament is normal over here, thanks to ResearchGate for this purpose. Here, there is a cruciate cross ligament that is deficient, and there is a genetic basis of it. Now, why do we study all this? What is the great point of it? So much so that the normal physics could be studied, and there can be re-establishment in a case of a joint surgery, joint replacement, or even an entire limb replacement. A very simple diagram, but then this. There is a matrix degeneration or degradation, and which is increased. Aggregants are damaged over a period. Type 2 collagen also gets involved, and matrix metalloproteinases are there, which also increases the degradation. Adamants is a type of matrix metalloproteinase, and TAMP, tissue inhibitor of MMP. So these things will be remembering. Matrix and collagen type 2, adamants and TAMP. Now coming to this diagram. This is a diagram of the normal collagen. See how well there is a network of it. This is the type 2 collagen that is there, collagen fiber. And the aggregant molecule is important in maintaining the connections between them. Hyaluron forms the base for the interstitium. In a case of osteoarthritis, you can see the break. I do not know to understand or help you beyond this. Anyway, I can see that the aggregant is getting lost and there is a widening and a loss of the collagen fibers. The matrix is also undergoing a degeneration. Usually what happens is there is a kind of loss and then there is a kind of replacement. But in a case of osteoarthritis, beyond a point, it becomes a permanent damage. COMP is another one, matrix proteins. Cartilage oligomeric matrix protein. I do not know it. If you go to the text, there are multiple other subsets which are given. We need not bother about it. But then we'll just mention that there is a cartilage oligomeric matrix protein. And see where all it is involved. Intervertebral disc, cardiovascular diseases, rheumatoid arthritis, osteoarthritis, tissue fibrosis, psoriasis, endometriosis, and very rare other diseases. Because if you go to the net and then search for it, you'll be going in different directions. And there are pioneers who have done a research in each of these. This is the reference for this particular diagram. You can go to the text. Now there are certain pro-inflammatory, certain anti-inflammatory mediators. The pro-inflammatory mediators is the list given over here, and this is the list of anti-inflammatory mediators. If time permits and if you can memorize it. Otherwise, just to remember that the pro-inflammatory mediators can lead to all these changes. There can be an initiation, there can be a progression, alteration in the cartilage and the matrix turnover, stimulate the matrix metalloproteinases, and there can be the suppression of the tissue inhibitors of matrix proteinases, and there can be a flaring of the inflammation due to interleukin 6, 8, and 17. So this one we'll be seeing. Nitric oxide is another one. It has been mentioned over here. There will be increased production of nitric oxide, which again can lead to the activation of interleukin 1 and tumor necrosis alpha. So these are the functions of it. So it actually protects the damage of the matrix. Apoptosis plays a role. So there is a change in apoptosis. It increases the longevity of the chondrocytes. It keeps the matrix 3D intact. Increased apoptosis will be seen in a case of matrix degeneration. And there is a stem cell above the cartilage that is controlling its turnover. Once the matrix is destroyed, the cartilage cannot be repaired completely by the stem cells. So these are the things. In osteoarthritis, apoptosis is increased. This alone we will be remembering, and this is a good chart for us to remember. If you find it difficult, go to this line diagram. This is the synovial fluid. This is the cartilage lower down. This is the synovial membrane. There are certain inducers of apoptosis. So there is a chondrocyte. It undergoes the degeneration. Caspase, etc. You people would have heard of an apoptosis. So there is an activation of these degenerating factors, adamants, MMP, aggrecan, etc. And you find that type 2 collagen, it undergoes a damage. So this is what we are seeing in a case of osteoarthritis. The reference is given below. I would like you people to kindly go through. This is a beautiful sketch that you people can very easily draw in your examination. So this we have already seen. If it is too difficult and complex, very simple. This is the early stage, and the later stages, there will be this is the cartilage over here, and this is the cartilage, and this is the bone. I find that there will be the spurs of the bone that are coming inside and damaging it. You can draw this particular diagram. The bone over here and the cartilage. Crystal formation. I am not going to go into the details, but please do remember, various crystals can be formed in the joint spaces. Uric acid in a case of gout. And then there is a condition called as pseudo-gout, which is a university question for you. The crystals in this case are calcium pyrophosphate dehydrate. These crystals are deposited and they will be leading to various inflammatory changes. So this is one. In this case, I am not finding needle-shaped crystals as you see in a case of uric acid, gout, etc. But instead they are polygonal or hexagonal crystals that are present. And incidentally, experimentally, they have seen that the injection of this particular material into the joint space in an osteoarthritis aggravates it. That is how they have diagnosed it. There are various other molecular mechanisms. It does not permit me to go into the details of it. Crystal deposition, we shall remember. Osteophytes. Osteophytes are nothing but spurs of bone that are formed into the joint space. Instability causes osteophyte formation. The net effect is there is an increased area of the articular surface. So this is an area, so also this, it is over here. The change in the phenotype of the midzone. Phenotype again is more of a genetic. The chondrocytes are becoming changed into the osteophytes. It is probably something like a metaplasia. You find that the columnar epithelium is being replaced by the squamous epithelium or vice versa. Injuries into the joint space can lead to the joint instability. And also there are various other things such as aging, degeneration, mechanical instability, etc., which can lead to this. So look at this beautiful picture of osteophyte thanks to Wikipedia. Radiologically, it has been marked over here. Bone cysts are also present, otherwise called as geodes. What are geodes? They are vague, spherical, colored hollow rocks. Look at this one. It is a rock, almost like a coconut that has been broken open. So I am finding a cystic space. And look at the color changes. A spectrum of colors has been given. So these are called as geodes, and these are the bone cysts. These are in the pelvic bones that have been found in a case of advanced osteoarthritis. Thanks to ResearchGate abdominal radiology. The synovium once again. So this is over here, this is the synovium. Kindly do remember, and look at this one. It is not lining by an epithelium. It is by the macrophages and then the fibroblast over here. Probably it is this one. They can mature into any kind of a direction, either into a cartilage or into bone or into a synovial tissue, etc. This is an important one, the molecular basis of it, and he has given the various mechanisms for it. It can be because of the cellular infiltration, the various cytokines and the chemokines which are being liberated, leading to a chronic damage. Or there can be the activation of the complements. There is an erosion of the joint space, a synovitis. And this is exactly what we had seen in the earlier picture. Look at this cartilaginous damage, and this there in this picture also. So what are the risk factors of it? So they are all given. It is not a study of pathology. It is pharmacology and the other subjects. So there can be pharmacological ones, the checking up by means of injecting hyaluronic acid. Non-pharmacological can be the treatment by exercise, weight loss. The other risk factors include age, genetics, gender, metabolic disorders, obesity, and joint. This is a very simple one for recollection towards the end, provided you have followed the earlier slides. Thanks to this. Load and osteoarthritis. You find that the chondrocyte function is dependent on the intermittent loading of the matrix, cartilage health, and low impact exercises. When people with a high weight keep on jumping, you pay the penalty for it. Repetitive high impact movements. Also the type of gait that we are having. These are all the various local risk factors, systemic risk factors, and what can be the symptoms and the severity of osteoarthritis that is developing. Finally, there will be a disability. Load on osteoarthritis, these are all the things. What can be the damage? You find it can be in the articulating surfaces, or it can be on the chondrocytes, or it can be the transductiviments over here. And large dogs have been used for the study. There is an increase in the proteoglycan and the various damage. Triathletes, I do not know this term, but probably associated with athletics. This is one of the last diagrams, a fantastic one, kindly follow. So there is a mechanical load. This is a normal cartilage of ours. So it is able to bear it. And remember this line, the tide mark. But after some time, there is a destruction of the cartilage. Normally what happens, there can be the resorption of the bone, there can be the reformation that is occurring. But after some time, it undergoes a sclerosis, there can be a damage. Abnormal load bearing. This is again a Beautiful schematic diagram thanks to nature. The points to ponder. We have dealt with the structure, the etiology, mechanism, differential diagnosis, morphology, molecular mechanisms, and the pictures. To me, pictures are pictures worth a million words. And this is one, Alice in Wonderland, through the looking glass. Thanks to LME. The last slide, nanotechnologies in the diagnosis of osteoarthritis and in the treatment of osteoarthritis. This is a reference for it. Various things have been given. Go through if time permits. But I'm worried. They say that nowadays radiology is replacing pathology. Whenever we have a doubt in the diagnosis, we are asking for the ultrasound picture, then the other radiological findings, their diagnosis, and then we are looking at the slide. While it should have been the other way around. Now, if radiology is to replace pathology, then are we heading to a world of nanotechnology replacing both radiology and pathology? Think about it. Don't forget osteoarthritis. It is a difficult university exam question from the recent advances for you. Thank you for your patient listening.